Bismillah. We'll start again with the second part of our main lecture with Dr. Hussein Assaf, Associate Professor, Department of Comprehensive Care, Associate Director, Advanced Education in General Dentistry, Case Western Reserve University, Ohio, United States. The lecture title is The Scope of General Dentistry Practice in the 21st Century. Dr. Hussein.
Thank you again. Is it projected? All right. Okay, thank you for coming back. Before I continue with the lecture, I just want to emphasize that what I'm doing here is not, my intention is not going to step by step on doing things. It's just an overview of what the general dentist does these days. They may do most of what we talk about, they may do part of it. As long as they have the training, they can do all of it. Now, I started this morning talking about things that we have available, procedures that we have, and techniques that we have available that are minimally invasive, that do not require a lot of tooth structure. And then we progressed from chemical treatment of teeth with acid, with microabrasion. We only have a couple of acids that we use in dentistry anyway. That's all the chemistry we need to know. To amalgam, which is still being used, which is still a good material to use, even though it's been shadowed by composite resin just because of the aesthetic demands of our patients. We talked about a little bit about what the technologies that we have available, how we can use the computer to our advantage, either with orthodontic or with doing crowns, fabricating crowns, designing crowns. As we see more patients that require more and more complicated treatment, we have more and more advances in those areas as well to help us help our patients. When we have, I think it should be on your screen. When patients are missing teeth, now, we're starting with a complicated case to begin with. But like the first slide I showed you, the one from 4,000 years ago, 5,000 years ago, the idea of replacing teeth had been around for a long, long time. And people used different techniques, used different ways of doing it. Very ingenious ways, if I may say so. I mean, the intricacy that in that picture always amazes me. How they put small holes on extracted teeth to pass the wire against it. Now, for a long time, we had that bridge to help us replace missing teeth, which required, if we go back, more destruction of adjacent teeth, even when there was nothing wrong with them. Actually, that picture from 5,000 years ago was a lot more conservative, less aggressive than what we did for bridges. Because all they had to do is take a wire, gold wire, wrap it around the abutment teeth without destroying any tooth structure. When we do bridges, we have to destroy the adjacent teeth. So with the advances of materials, It allowed us to do bridges, nice looking bridges, some all ceramic bridges. I'm not going to go over too much on the bridges. However, over the years, we had great advances into the replacing bridges, missing teeth. We always need to give credit when credit is due. When Brennemark in '52 showed that you place a titanium post in bone, it integrates. That opened the door to a tremendous advancement. Because of that, instead of destroying teeth now to make a bridge, we can just place a titanium post to replace the tooth, just the tooth that is missing, without destroying any tooth structure next to it. Over the years, actually 20 years now, there's been an explosion of interest in implant dentistry, in aesthetics, and now in adult orthodontics. So missing a teeth, take a post, a titanium post, place it there, let it heal, let it integrate, place a crown abutment on it and do a crown, and we're done. Now, because now we know that we have that option, it changed the way we're thinking. It's not only advances in technology, but the advances make us change the way we think. We used to take teeth out, wait, and give a bridge. Now we know there is an implant that we can use. However, we need to think ahead that when I am removing a tooth, I want to leave that option of placing an implant there for me. And advances in technology as well, and advances in technique help us now to be able to, that before we take a tooth out, part of our treatment planning, if it's we need to include the implant, whether we do it or not. However, you don't want to limit your options later. So we need to think ahead and preserve that socket once we remove it. Now we have artificial bone we can add, no matter what kind of bone, allograft, whatever. The idea is I need that socket to stay where it is. Because if I do not treat it and be proactive, I might end up actually not having the option of placing an implant, or maybe still placing an implant. However, now I need to do some things that are more aggressive to prepare the site before I place an implant. So planning ahead will save us and the patient a lot of trouble and headache. Or the day you take the tooth out, now you can place an implant. You take the tooth out, place it immediately, then we don't have to worry about the socket preservation as well. We still have to graft a little bit, but not as much. That's actually a case we just delivered last week. We just came in, place an implant, wait 3 months, it's a lower. Have a nice zirconia abutment, make your crown, cement it, we're done. For a while, we didn't have those zirconia white abutments. So we had to just contend with titanium abutment. And that at sometimes, especially in a thin biotype or a thin gingiva, we ended up with the same kind of problem that we had with the PFM, the porcelain fused to metal crown, where we had I was told to use this, where we had that shadow showing through. If the patient has a low lip line that they do not show, it's not a big deal. But if they smile and they show the tooth and the gingiva, that becomes an aesthetic problem. Now for this case, we needed to remove it, place it just to address that aesthetic problem. That's, I'm sorry. Oh, is it working? You gain access to the crowns, remove them in one piece, especially when you did not place it. You don't have a choice. But one thing here, do you notice that thing right there around the margin? What do you think that is? That's the cement. When we cement, whoever cemented those crowns, we did not remove the cement. That becomes a big problem. That can actually lead to failure of the implant. So take that patient, remove the old crowns with the abutment, place a temporary provisional crowns, let the tissue heal, and we can take, because we know that now we can use different kind of abutments. That would be a good option for it, especially with a patient that is aesthetically demanding. That will help us hide that metal underneath. And just go ahead and make them new crown. So basically, for every problem we have, there's always something we can do. Thing is, we need to know about it. We need to know what's available there. That's another patient. Sometimes you have to be creative. This patient, we needed to remove that tooth. We call it number 8. I don't know what system you use here. The upper right first incisor. And place an implant. Patient did not want anything removable. So you have to build on everything else you know. From bonding, from implants, from making a provisional, and try to satisfy that patient. That's the tooth after taking it out. Why don't we use it as a provisional, as a temporary? We know bonding works. We know bonding works very well on enamel, and we're going to be bonding on enamel. Let's take it, remove the tooth, place an implant. I cannot place a provisional on that implant. At that time, you can, and sometimes you can't. If you can, it's great. Sometimes you don't have the proper torque, you can't do it. And just bond it to the adjacent teeth. Let it heal. That's what happened 6 months later. Now, the patient was attached to her tooth. She really didn't want to let go. 6 months later, we had to expose the implant. Now we have to make her provisional even for 2-3 weeks. She still did not want anything removable like a flipper. So let's abuse that tooth. That's still her natural tooth. Now it's hollowed. Just hollow it. You have your temporary abutment. And with the bonding, bond composite to it, to the temporary abutment, and create basically a natural, right here, a natural screw retained temporary. Deliver it, leave it there 2-3 weeks. This one probably went about 4 or 5 weeks before we bring her back in to take the impression. But now I have something to give her in the meantime until we get the final crown. And by doing that, you can see how, how the tissue healed very well. You can see the appearance of a papilla around it. Didn't create a papilla, it's just the appearance of a papilla. So there are a lot of things we can do. We have to build on our knowledge in all different disciplines that we, as a general dentist, are exposed to. Now, in the fully edentulous patients, it becomes even a bigger problem. For a long time, that's what we did, the denture. That's a gentleman falling asleep and the denture falling out of their mouth. For the younger kids, the students, probably they haven't done a lot of dentures. When you do a lot of dentures, you're going to probably hate it because you never satisfy the denture, the patient. It never stays in place, no matter what we do. Right? Maybe initially you might be okay, and with time, as the ridge resorbs, we have a problem. But luckily, we can do something now. Like I said, there has been an explosion in the way we think about implants, not only for fixed and to replace single unit, but now you have implants. You can hook up the denture, whether you place four implants, whether you place 2 implants, minimum 2, 4 is better. It's still gonna retain that denture a little bit better than the gentleman we just saw. So this here is for locators. You have a couple, you have the attachment in the denture, you place it in there, and that keeps it in place. With 2, you're still gonna have some movement, a little bit, micro movement. The more implants, the more stable and retentive it's gonna be. But for patients who don't want to have anything removable, we have to come up with something else. You still have the options to have fixed. Oh, I didn't do that. All right, good. You still have the option of having implants and bridges, or you can have what you call a hybrid. It's a removable denture that is fixed to implants, screwed in place. So you have we're not going to talk about the numbers of implants needed here, but you have, in this case, 6 implants. You have a bar. You connect, you place the teeth, and that's a denture that you screw on top of the implant. Keeping in mind the ability of the patient to keep it clean. A lot of times, sometimes we forget about the patient keeping it clean. Yes, it can be a success. We do everything looks beautiful. However, if we do not make it easier for the patient to keep clean, no matter what we do, it may fail. And it's not the patient's fault. Sometimes it's our fault. We did not make it so they can take care of it. Okay. Oh. That's another case of hybrid. If you look, can you see I can't see it here. In some cases, some landmarks or some vital structures prevent us from placing the implants the way we want to, or the place we want to. In this case, for example, if you look at the sinus floor, too low, there's pneumatized sinuses that prevent us from placing the implants where we would like to allow us the spread of the implants, anterior, posterior spread. One way is that probably this one has been now 15 years, I think, is to angle the posterior implants. Place implants that are not axially positioned up and down like that, but more angled posteriorly to allow a wider spread of the implants. You can place 4, you can place 5. So some of them are going to be angled, some of them are a 45-degree angled maximum, and some of them are going to be straight up and down. Not going to go over the step by step, but again, this is immediately after the surgery. Because we are placing a denture that is going to be splinted altogether, it's going to splint all the implants, it allows us to actually deliver that denture the same day as the surgery. So the patient does not leave without teeth. So they come in the morning, have the teeth removed if they have teeth, or have the implants placed, and immediately see the patients here. These are temporary abutments. A denture that has been previously done And if they have a denture that fits well, we can modify that as well. Place holes in there and pick up those abutments and becomes one unit. Then you can modify it by cutting the palate, and you have a horseshoe denture that's going to go sit in the, screwed in place on top of the implants, and the patient does not leave without anything. It's really not, psychologically, it's not easy to tell patients we're going to take teeth out and you're going to go around for 6 months without anything. Or we can give you some immediate denture that's not going to stay. And you're going to be coming every 2 weeks to adjust it. All right. Is he making good? Now, the number of implants, we can place as many implants as we want to. But do we really need to? 4 implants has been shown to be just fine. As long as the denture is splinted, as long as you have a good spread, and that's why you angle those implants. One term for this is the all-on-4, but all-on-4 is basically a trade name. It's one company that started with it. Oh. And that's the dentures delivered immediately, upper and lower, the same day. All right. As a general dentist, are we going to do this? No, probably not. Not the surgical part. But can we do this, the restorative part? Absolutely, why not? If we respect the principles, if we know, if we have the proper training. That's before and after. Now, in some cases, patients don't have any bone, and we still can do something. You have those huge implants. Oh, sorry. Those huge implants, they are anywhere between 30 to 50 millimeters implants. So the surgeon can place them, actually anchor those implants into the zygoma. Still angled, and the other 2 implants toward the front, more axially positioned. To us, does it really make a difference as a restorative dentist? No, because we're going to treat this the same way, whether it's a 10 millimeter implant or a 50 millimeter implant or a 100 millimeter implant. Because what we see in the mouth is going to be the same thing, the attachment. I saw that some people refer to that as the third dentition. So you have your primary dentition, you're done with them, you have your adult teeth. Now you know you don't need to take care of them, right? Because we have the third dentition waiting for us. No, but you can refer it as a third dentition because that's a God-given. It was not available, always available to our patients. But now we have more options. Now, implants has been, well, called the biggest advances in dentistry. And it's, in my opinion, it's one of the biggest, absolutely. As long as we don't go crazy with it. When I talk about explosion in dentistry, I found this online, actually. Somebody sent it to me. Every single tooth is replaced by an implant. What's even more impressive is this. If you look at the molars, every single root was replaced, not every tooth. Do we really need that? I'm surprised, actually. Look at the molar, upper molar. You have three implants, 3 roots. So yes, it's a great advance, but let's not go crazy with it. All right. And it's still a great advance if we place them correctly. All right. We, as the restorative dentist, whether general or not, placing the implants is only part of it. And it's not going to do us or the patient any good if they're not placed correctly. What are we going to do with this? Personally, I refer to Dr. Fadul. So it's a great advances, but we need to understand it, we need to use it properly, all right? One way was to provide your surgeon with a stent. So the surgeon knows where to place the implants. If you're not placing them yourself, at least we need to communicate with the surgeon, here's where I want the implants. And that's based on our final product. We have the vision as a general dentist, restorative dentist. This is where we want to go. And the specialists are there to help us get there. But we need to tell them where we're going. Otherwise, they're going to take us wherever they want to go, like in the previous slide. So that's one, the one way of making a stand to tell them, okay, this is where I want to go. The problem is what? Those stents are made on a stone model. So you take an impression, you have a stone model, you send it to the lab, make me a stent, surgical stent, this is where I want the implant. Now the lab, or even if you're doing it, if you only have the stone, you don't know how much tissue you have. You don't know where the bone is. So what we do is place the hole in the middle of the ridge, the middle of the space, and hope that that's where the bone is. So you send this to the surgeon, or you're doing it yourself, you reflect the tissue, you place it, that hole is either all the way out facial or all the way out lingual, and the bone is not near it. Right? So if we're lucky, it's right there. But if it's not, so what do? You take that stent and throw it out. You can't use it. All right? Or the surgeon can't use it. Now we have the ability to actually use the bone, see the bone in 3 dimensions. So before we even start the surgery, you can have a combined scan. It gives you a 3-dimensional image of your patient. You know where the tissue is. You know where the bone is. You can plan the placement of the implants exactly where you want them to be, using something like the patient's denture. And fabricate this, using this information, can fabricate a guide that is based on that 3-dimensional model. So now, the surgeon, all the surgeon has to do, take that model, place it in the mouth, and just place the implants through those holes. There is no room for guessing. I'm not going to guess where the bone is. I know exactly where the bone is going to be. And I know if it was treatment planned correctly, the implants are going to be where we want them to be able to provide what we plan to provide. Same thing. Like I was saying, whether you have a long implant or short implant, that's all you're going to see in the mouth. So as a restorative, that's what we care about, unless you're placing them. All right. I want to finish. I have probably 5-10 minutes left. I want to finish with a few notes about comprehensive care. That's a quote, I'm not going to read it, from McCracken. And probably if you done removable partial, you know the name McCracken. It's basically his definition of what comprehensive care is. Because as a general dentist, we have all that, or restorative dentist, all that information, all that knowledge, that to allow us to be able to provide care to the patient in a comprehensive way. Not only problem-focused, you have a cavity, we're going to do a filling, you have a missing tooth, we're going to do an implant. Now, we need to treat the patient as a whole. I'm not going to read the definition, but basically some of the elements are underlined. We need to Basically, first one is complete diagnosis. When I mean complete diagnosis, a comprehensive diagnosis. Sometimes in school now we're getting better at teaching our students about making more comprehensive diagnosis, not fragmented diagnosis based on different specialties. So yeah, I mean, you have complete diagnosis, you need a full treatment plan based on your comprehensive diagnosis. One thing that we always forget is the last one I want to do, the maintenance and the prevention. So a lot of people, we know, yes, we hear about, comprehensive care. But when you ask people, okay, what is comprehensive care? What you hear is total care. Okay, what is total care? Well, we'll talk about diagnosis, treatment plan, we'll talk about the procedures, but there is the prevention element that we always forget. There is the maintenance element. Whatever comprehensive care we provide, we need to make sure that the patient can maintain that new health status. Okay? Now, in dental school, this is directly mostly to the students here. Dental school, we get the basic knowledge. It's basically, we are taught in dental school how to learn. The rest of it is continue learning. We need to build on. That's a quote that we see what we want and we treat what we see. Or you see what, you see what you know, or you diagnose what you know. Out of dental school, we really don't know much. We know the basic. We need to know what's out there to allow us to help provide the best care to our patients. So the more we know, the more we see. The more we see, the more we know how to treat it. Okay? For example, probably we can, get out of dental school, no problem doing this. Take a quick impression, have a crown, you have a good ceramist, they'll give you a nice crown. But when it comes to the complicated cases, we need more than that. We need to see more. If you think about a patient, the patient always has to be the center of our attention. Everything has to be patient-centered. That's what comprehensive care has to be, patient-centered. As a recent graduate students, this is how much we know. We have a narrow field of vision around the patient. It's just because this is how much we know. So this is how much we're going to see. So what we do, we rely a lot on the specialists to help us with diagnosis, to help us with treatment planning, to help us with providing care. As we gain experience or as we get into more advanced training, we widen that field of vision. So now we're looking at the patient from a wider vision where we can see more. Because we know more. We can treat more. Okay? Now, however, with increased knowledge becomes increased responsibility too. The more we know, the more we are responsible. It's a lot easier when you don't know much and said, the specialist will do it. The thing we forget that patient's coming back to us as a restorative dentist. So it's not enough that now we know how to do it, we know what to do. Doing it is not enough. Take this patient, for example. In that patient, not going over the findings and all that, that patient is going to be at the center of our attention. As a general dentist, whether we do the treatment or not, we need to know what needs to be done. Not only what needs to be done, we need to know how and when it should be done. So our responsibility goes from providing care to actually being more of a coordinator of care as well. So we were going to decide when the patient goes where. We'll go from send them to perio, come back, and we're going to have arrows going all over over the place, from the specialist to us, from us to the patient, from the patient to the specialist, from a specialist to specialist. So with our knowledge, we need to coordinate all that treatment as well. Otherwise, we will not be able to provide that care at all. My intention here, like I said, was not to provide step by step. It's just an overview, overall look on what is available to us in the general practice. And compared to 20 years ago, tremendous amount of knowledge, tremendous amount of advances in technology. I mean, you students right now, you live in a very exciting time in dentistry. So with that, I thank you, and if you have any questions or comments, please.
Let's put our
Feel free.
hands together
Or-
for Dr. Hussein. Thank you very much for
Thank
this
you.
excellent presentation. If there is any question from the audience. And now we reach to the end of our first lecture, and we will be back inshallah with the second one. Thank you, Dr. Hussein.
All right, thank you. Thank you.